Hi, this is Dr. Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of welcoming back to the podcast Dr. Rob Coleman. Rob, always great to talk to you, and thank you so much for agreeing to this invitation. Today, we're going to talk
Well,
about a recently published study in the Journal of Clinical Oncology. And the title of that study is Gemogenovatucel-T Advantage in Clonal Tumor Mutation Burden High Ovarian Cancer. Rob,
there you go.
thank you so much. And I am so glad I got the name of
You
that
made it.
drug
You made it. Oh
on
yeah.
the first try.
I love it. Yeah, thanks again for having me, Pedro. It's always wonderful to be with you, and thanks for for highlighting this paper. It's been
Yeah,
fun
no,
to work on this
we're
project.
looking forward
Hmm.
to talking about it. As always, of course, obviously we have lots of questions from our fellows as well that we're going to get to in a second. But I
Hmm.
wanted to start by asking you to put this trial in context in the setting of patients with ovarian cancer. What was the data to date, and where did you see a gap in knowledge here?
Yeah, this project, this is project been going on for some time. We've been working with this particular patient-specific derived kind of vaccine targeted immunotherapy several years now. And so as it's been neat to watch it evolve as we've learned more and more about the tumor microenvironment, what harnesses the immune system, how it activates in response to ovarian cancer, because we've had a lot of essentially negative trials with immunotherapy in ovarian cancer. But really the motivation to work on a project like this was really to target a group of patients who have had induction therapy and then are kind of left with the question, what do we do next? And as over the many years now of maintenance therapy, we've gone through multiple phase 3 trials, most of which have not shown any benefit in overall survival, although some of them have produced some improvement in progression-free survival. But that legacy, has really been has been nuanced much more categorically, because now we have these genomic signatures of patients, and as you know, from the 2015 through 2020, we started to see the emergence of identification of patients who carry a BRCA mutation or have homologous recombination deficient tumors, and those we saw in the very select, isolated cohort of patients with the BRCA mutation tumor, that there was a potential for an improvement in overall survival. We'll see that data mature as time goes on, but those are really the first kind of events that we saw that changed this natural trajectory. So our motivation was to figure out a way to identify a similar cohort of patients that potentially could benefit from an immune-based strategy, but we wanted to be very selective in who we were targeting for this so that the immune therapy had the best chance of working. So that was really kind of the motivation.
Mhm.
And so we kind of whittled away at it through multiple different manuscripts over the last, oh gosh, 10 years now.
Yeah. So now, getting specifically into this study,
Mhm.
what was the objective here and the patient population that you evaluated?
Mhm. So this group of patients came out of a trial that we reported on several years ago, which was just taking patients with advanced ovarian cancer who had had surgery, and we were able to create a tumor specific, so very patient specific targeted immunotherapy product. And if those patients achieved a complete response to their induction treatment, then we were able to give it to them as a maintenance therapy. We randomized these patients. Now, at the time, in terms of genomic signatures, the most definitive signature that we had was whether or not patients carried a germline or had a somatic mutation in the tumor for BRCA, for BRCA mutation 1 and 2. So that was kind of our primary evaluation of this tumor of the study. And so in that initial paper, we showed that there was definitely a strong signal there um, for a lasting effect. So the trial actually we looked at for relapse-free survival. We used that endpoint because these patients didn't have any measurable disease, so it really didn't fit the criteria for progression-free survival. But for relapse-free survival, we we saw that there was a strong signal there, but what we didn't expect to see was that there was such a strong signal for overall survival. And so we started digging away at that. And that's kind of led to the motivation for this current paper. But along the way, so that was about, that was several years ago, maybe almost 10 years ago now that we started that project. But we started looking at these samples more carefully and in the patient population more carefully. And as I mentioned, the science moved on. And there was a really pivotal paper about 9 years ago that said, hey, listen, there may be something about the type of neoantigen exposure that is actually activating this immune system. And so that's where we got into this idea of that there was potentially a clonal expansion. And if we could identify whose tumors actually had a high level of this clonal expansion, that there was probably a better shot at a immune-based targeted therapy for introducing a long-term lasting benefit. So the initial studies, we broke that down. We then showed that this HRD signature, which included not only the BRCA mutation, but then we also used the commercially available HRD assessment from Myriad's assay to define the HRD test positive and test negative population. And so while we were in the process of evaluating the efficacy of this tumor vaccine in this patient population, we learned about how clonal and subclonal populations of cells can have a differential effect on immune activation. And that's where we really saw where we thought this was going to go. We learned that in these tumor types that had very specific, patient-specific, tumor-specific clonal expansion of neoantigens, that's where this particular vaccine was most effective. And that's what led to the current paper.
Excellent. This question comes from Beate Sarta in Latvia, one of our fellows now in the journal, and she was asking, can you please specify how HRP was defined, whether it was required both germline and somatic BRCA wild type status, and how missing or indeterminate BRCA HRD results were handled?
Yeah, it's a really good question, and there's a lot of insight into this because I think what the question is addressing is something that we don't really have, and that is how do we define HR proficient tumors? Right now, we can identify HR deficient tumors either through the categorization of a BRCA mutation, or if they meet some of the selective criteria that we've identified in BRCA wild type tumors that have a characteristic signature that's similar to patients who have a BRCA whose tumors carry a BRCA1 and 2 mutation. We do not have a commercially available test that assesses for HRP. So right now, our idea of homologous recombination proficiency is the absence of HR deficiency. And it may seem like a subtlety, but in the eyes of the FDA, we have no commercially available test that has been validated on the HRD signature. So I just want to make sure that's called out because it's actually an issue in front of us as we're developing our current set of trials for maintenance therapy in ovarian cancer right now.
Hmm.
So having said that, we did in this study is that as I mentioned before, the initial assays were basically to look for BRCA1 and 2 mutation in germline or tumor. That was one component of HRD. The second component of HRD, which came later, was a reassessment of HRD through a commercially available test for HRD, which was the Myriad test. So there were a few samples that as there is with any one of these, that were not accessible. So they were not included in the analysis. But we then looked at what was going on with respect to neoantigens, tumor-specific neoantigens in those three categories: BRCA mutation, HRD test positive BRCA wild type, and absence of both. And we were able to identify in a subsequent paper that the neoantigen exposures, that the clonal expansion was highest in the HRD test negative cohorts. So that was really how this was, decided on.
Okay. Now, let's actually talk about the results of the study, the
Mhm.
things you'd like to highlight, and then we'll get into some of the questions by our fellows as well.
Yeah. So again, and it's a little bit. I always have to be mindful of the sampling that we've done here. So remember, this was originally a phase 3 trial run through multiple countries. And it identified a relatively narrow cohort of patients ultimately that were analyzed. So we have a sub cohort of that cohort. So this is, it's always going to be a little bit of, with the intention of this is hypothesis generating. And we're looking at a total of 23 patients in this particular analysis. But what was really shocking to us was that we saw in the way that the prospective analytical pathway was identified was to look at this overall survival in this cohort of patients whose tumors had this expansion, this tumor mutational the clonal expansion of TMB high in this HRD test negative cohort to see how they did relative to controls. And what we found was that there was a substantial improvement in overall survival with the hazard ratio of 0.23, and obviously this was highly statistically significant. But again, I say that with some caveat because again, this was a subgroup of a trial that was already conducted, and so we have to always take that with the idea that this is definitely hypothesis generating, but it's a very strong signal for overall survival. We hierarchically assess this in the ITT population, which of course then includes patients who we demonstrated, and I mentioned before, might not have as strong an effect. These would be the HRD test positive cohort of patients. And so for overall survival, we saw a lower effect in that particular general population. And then the hierarchical testing was supposed to move on to relapse-free survival, but it stopped there in that analysis. We didn't go further in terms of our hierarchical pathway, but we did look at it anyway, just to see what was going on. And so there does seem to be a trend towards improvement in the delay for progression.
Excellent. This question comes from Giuseppe Parisi from Policlinico Gemelli in Rome. And he's asking, in this study, we focus on clonal tumor mutation burden. Conceptually, why should clonal mutations be a better biomarker of durable immune control than total or subclonal mutation burden, especially in a tumor as heterogeneous as ovarian cancer?
Hey, you got some smart people out there. No, this is a great question. And
Nothing
this is
but the
actually
best.
yeah, exactly. Well, this is actually what got me really excited about this project because, we had, obviously participated in a lot of, checkpoint inhibitor trials in ovarian cancer, colossal negative in multiple different extremes. And so we were clear that this identification of a checkpoint inhibitor in ovarian cancer as a maintenance therapy was really not hitting the mark. So, but I always felt like there might be a subgroup within this group that could potentially be benefiting. We just weren't identifying correctly. So what we learned through, as I mentioned, some of the previous preclinical work that we did was that when the clonal expansion of this particular tumor mutational burden is an event that occurs when the cancer is formed. So all of the cells of the cancer essentially have this clonal expansion of these specific neoepitopes. In a subclonal population, which is what we see frequently in these metastases, and we see them actually with tumors that carry an HRD test positive signature or a BRCA mutation, what we see is that particular subclonal population can actually counteract the natural immune response. And we've seen this in some other tumor types as well. So that what we're seeing is that although tumor mutational burden is one measure of these neoantigens, having it being specifically clonal and the vaccine being developed for those clones, that this would be the ideal population that takes out the negative contribution of the HRD test positive and BRCA mutated tumors. So that's why we thought this might work the most. Again, the hypothesis is pretty strong. And it's not just in ovarian cancer. We're seeing this in melanoma, and we've seen it in some other preclinical work, which suggests that if you have a clonal expansion of the primary tumor and a high level of those clones available, that leads you to a very high level of tumor-specific neoantigens. So if that targets the immune system, or that becomes recognizable to the immune system, it becomes highly sensitive to the T cell response. And that was, kind of, again, It's predicated on a small number of samples, but it really fits nicely with the biology.
Yeah, and interesting that I did. It crosses other tumors as well.
Hmm.
So very interesting. So Nicole Chris from the University of Western Australia, she's asking, the clonal tumor burden high HR proficient population is uniquely responsive to the immunogenic vaccine therapy. What do you think is the mechanism that is preventing this response in HR deficiency?
So as I think I just highlighted, is that the HR deficiency for both BRCA mutation and BRCA wild type HRD test positive, they have a very high subclonal mutational burden. So remember, the original tumor in the HRD test negative cohorts are essentially the tumor mutations that drove the tumor to begin with. The HRD test positive and BRCA mutations have a number of subclonal populations in addition to the clonal populations that started the tumor initiation. So it's more heterogeneous. I kind of think of them as from the standpoint of the neoantigens and the immune responses, that the HRD test positive and the BRCA are kind of the negative drivers because of their impact on dendritic cell presentation and the kind of the immune tolerance. That drives that side. This side drives the immune activation. So they're kind of counterproductive. And so we found is that in these tumor types, especially as was mentioned by the previous question about the heterogeneity, is that we see this mixture of clonal and subclonal populations within the tumor. There's just a lot more subclonal in the HRD test positive and BRCA mutated tumors.
Excellent. So, Rob, this next question is a perfect example. I tell the fellows just one question for the authors of the study. So they're so enthusiastic that in one question, they often will place three questions.
Multiple.
So
Exactly.
this is Vincenzo Tarantino from Gemelli also. He's asking,
Mhm.
from a biological standpoint, one might expect that HRD tumors with a truly high burden of clonal mutations could also benefit from a neoantigen-based vaccine approach. However, in this study, the clonal tumor burden high signal appears confined to the HRP population and disappears when
Correct.
HRD patients are included. Do you believe this
Correct.
reflects a fundamental biological limitation of HRD tumors for vaccine-based immunotherapy, or rather limitations in how tumor mutation burden and clonal architecture are currently defined and measured in HRD disease?
Yeah, I think the answer to that is yes. So, so I think the question is basically answering itself. As I mentioned, the HRD test positive tumors generally have a large number of a subclonal population mixed in with some of the clonal expansion. So they're already at a compromise. However, even within the HRD test positive has a clonal high, it's still a mixed population that is acting against each other. So you have parts of the tumor that are counteracting the parts of the tumor that are trying to activate. So they're working against each other with respect to this specific immune response. That doesn't mean that there couldn't be an opportunity for expanding those populations as we get better, more data and more patients to see whether or not there is a HRD test positive subcohort that we can actually include in here. That's something that we will definitely want to include because that would give more opportunity to our patients. But right now, from the way that we've measured it, it's basically counteracting that specific component of it. So we really need to figure out, right now we used a median to identify high and low as the TMB, and it may be that cut point is not appropriate for all of the populations that we're studying, and that would definitely need to be expanded with a bigger patient population.
Okay. Back to Nicole Chris from Australia, and she's
Mhm.
asking, median relapse-free survival in the clonal tumor mutation burden high HR proficient population treated with the immunogenic vaccine therapy was 10 months. Yet, median overall survival was 68 months.
Mhm.
Vaccine seems to enable these women to, quote, live with their cancer for longer. Do you have any suggestion that the sites of recurrence or the volume of recurrence was different in the vaccinated women?
Yeah, we didn't really have a good handle on that. And I guess the sample size is also pretty small to be able to clearly identify that. We didn't really, it would have been nice to have more information about that. But I do think that this points to a feature that we're seeing across immunotherapy in general, which is that there's immune education that happens with this first exposure, and we get some effect with the immune therapy right away. But once the memory sits in, what you then are preventing down after multiple recurrences is this lasting effect that again is in this case will be targeting the specific neoantigens that we started with. So this is the clonal component of it. And so as your other question identified is that ovarian cancer is obviously a very heterogeneous tumor. So we would expect that we would get a heterogeneous result. But the part of the tumors that are recurring that have the same neoantigens, those T cells have already been educated, and so that can lead to this with improvement with each of the treatments going ongoing.
So, another question on this very robust overall survival. This is from Vincenzo Tarantino. He's asking, should this finding be viewed primarily as a predictive signal of Gemogenovatucel-T, or could it reflect selection of a biologically favorable subgroup rather than a true treatment effect?
Yeah, that's a good question. It gets back to how we assess prognostic and predictive biomarkers. I think that the way I always look at this is to look at the performance of the control arms and the experimental arms in the absence or presence of the biomarker, and we really don't see a difference there at baseline. So it doesn't seem to be performing as a prognostic biomarker, but it definitely is acting as a predictive biomarker because it's only in that select cohort of patients that carry the biomarker that we're actually seeing the benefit.
Yeah. And a somewhat related, similar question, Leila Abulazzi from Georgia, she's asking, are there plans to directly evaluate total tumor mutation burden versus clonal tumor mutation burden in terms of predictive accuracy?
Yeah, that's a good question. I think that the right now the TMB in general has, at least with respect to immune checkpoint inhibitors that have been evaluated in the past, has not been selective enough. In fact, if you look at it, the TMB, global TMB for ovarian cancer is very low, which is probably why we don't see efficacy on the PD-1, PD-L1 inhibitors in the randomized phase 3 trials. However, a component of this is actually that clonal specific piece. And that's why we went after that, because these were initiating mutations that were propagated through from the beginning to the metastatic environment. And so we feel like those would be a better way to assess efficacy for this kind of targeted treatment. Remember, the vaccine itself is not just going against like the absence or presence of immune checkpoints. It's going after specific tumor. The patient is their own control. So there's their own uh, derivation of where these antigens are coming from. So it is a very highly selected, patient-specific targeted immunotherapy.
Yeah. This question comes from Naya Seminario in Spain, and she's saying, given that the survival benefit was restricted to this population, HRP
Mhm,
C TMB high subgroup, and the comparator was a placebo rather
mhm.
than PARP inhibitors, how confident are you that the CTMB is a truly predictive biomarker rather than a subgroup effect?
Yeah, I think this was a question that I was concerned about initially, but as we got more and more data with the efficacy of PARP inhibitors in the HRD test negative cohorts. You may remember that niraparib, for instance, was the only FDA approved PARP inhibitor for all comer population. And as you know, a couple years ago, the FDA reviewed the overall survival data from those trials and also in the recurrent setting, and demonstrated that and suggested that there was really no efficacy in those cohorts. And they recently then restricted the label for PARP inhibitors in the HRD test negative cohorts. So it's no longer available. So really, placebo is the appropriate control in this day and age. Mhm.
Excellent. A couple more questions. Alvin Matthew from Houston Methodist. He's asking, what would you want to see in the next generation trial design based on these findings?
Well, as a purist on, for statistical design, again, these are hypothesis generated. The thought here is that we have to prove this in a phase 3 setting that's appropriately powered, which will take some effort. This is a subgroup of a subgroup, and but it is entirely feasible to do. Uh, if you think about the overall survival impact with the hazard ratio that we showed at 0.23, you probably wouldn't need a lot of patients to be able to show that, but it will take time. So we'll need because these are event-driven analyses, so we'd have to wait for that event to occur. But I do think that the ability to manufacture this particular tumor vaccine, um, has really enabled us to start to think about a phase 3 trial that could be appropriately powered and actually prove this.
Excellent. So, Rob, it's a last question, and I know
Mhm.
your time is limited. You're currently at AACR. As you know, our
See
last
my pen?
question
See, I
is
got my pen.
that's right. As you know, that our last question now is always from AI generated question of
Love
your
it.
article. And what AI is asking you is you report a dramatic overall survival advantage, has a ratio of 0.23, approximately 49-month difference, yet the relapse-free survival signal is modest and not statistically robust. Can you explain the biological and clinical mechanisms by which this intervention produces such a large overall survival benefit without a commensurate effect on relapse-free survival, and how you exclude this possibility that this overall survival difference is driven by post-progression therapies or imbalances in subsequent treatment?
Well,
Wow.
I think that, yeah. Well, I mean, and actually, your other non-AI people asked this question as well. So we did address a little bit of this before,
Yeah.
but I think that the answer is that this is not unique to this particular asset with respect to immunotherapy. We have seen immune education as being a principal driver of long-term overall survival in multiple tumor types. In fact, some of the most dramatic effects we've seen, for instance, in melanoma, where we know the checkpoint inhibitors seem to have a strong effect, is that they have a very L-shaped curve, so that there's a big population of patients that don't benefit at all, and there's these tails that show up at the tail of the curves that can translate into overall survival. I would say that it's likely that, as I mentioned, that the relapse-free survival, again, it's a small cohort of patients, but the relapse-free survival is looking at the immediate effect of the tumor neoantigen, but the long-term efficacy, the overall survival, is actually looking at the immune education. And I would expect that all of the post-progression therapies would be benefited by this immune education. So you're right. It would be yes and yes, because I think yes, it is part of that, but it's also an underlying immune education to the clonal recurrences that come back. And so maybe if the clonal recurrences are not as a big a proportion of the tumor, then we might see less efficacy as time goes on. But right now, it looks like that's what's potentially driving this large difference.
Awesome. Well, Rob, thank you so much. Really great study. Thank you so much for obviously accepting our invitation to speak about.
Always.
I'm actually also personally very proud that I never mispronounced the name of the drug throughout the entire podcast.
You're really
Uh,
good. You practice in the mirror and it comes out just blah, perfect. I love it.
But no, I thank you again, Rob, for all that you have
Uh,
contributed to this field, and man, you continue to once again expand on all of the innovation and knowledge for the treatment of women with this type of malignancy. Thank you.
yeah, it's always a pleasure. And thanks so much for what you do. It's great to get this word out. And I really enjoyed it. It's always great to be with you.
Thank you.
All right, bud.